We now know a lot about Lyme disease, but that certainly wasn't the case when Dr. Stier first encountered the first Lyme patients that presented to him at Yale in 1975. How he and other scientists determined the disease's natural history and its cause is one of the great stories in medical science. Dr. Stier describes what he learned from Mrs. Murray.
She recorded other manifestations. She also recorded other patients that, as I began to work on it, I did not think had the same illness. It was not that it was all figured out. And I went to public health officials, I went to other physicians, I went to schools as a way of trying to find additional patients, and decided on a case definition of inflammatory arthritis in a child. We'd heard about adults being affected potentially. There were parents of children who thought that they had the same disease as their child. But it was more difficult to put that together. And we also decided on a rather small universe of the Lyme, Connecticut area. It was 3 communities, Old Lyme, Lyme, and East Haddam, which are all together, in which my goal was to try to find all children who had a diagnosis of inflammatory arthritis.
Dr. Stier and his colleagues established a case definition for this peculiar form of arthritis and then systematically assessed everyone they could reach in the Connecticut townships of Lyme, Old Lyme, and East Haddam, and fully evaluated everyone who had this odd form of arthritis. They reported these findings in the journal Arthritis and Rheumatism in 1977. When systematically assessed, one interesting feature became apparent. A quarter of these patients had a history of a rash. The rash was described as an erythematous papule that developed into an expanding red annular lesion, usually with partial central clearing. The lesion, which was often on an extremity, became 20 to 50 centimeters in diameter in some patients. The extreme clustering of this disease suggested an infectious etiology. Dr. Stier and his colleagues also recognized that the rash was similar to one that had been described before called erythema migrans. And erythema migrans have been described in Europe and was thought to be caused by bites from the Extracutaneous ricineus sheep tick. Erythema migrans also had been observed in the United States in the Connecticut region. The perplexing issue was that the European variety of erythema migrans wasn't associated with arthritis. Putting together the constellation of the arthritis being clustered into a few towns, and within certain blocks of those towns, and that about a quarter of the patients with arthritis had this rash that seemed like it was erythema migrans, and that in Europe erythema migrans was known to be caused by tick bites, Dr. Stier thought that tick bites somehow caused the outbreak of arthritis. Another clue was that people living in this part of Connecticut had noticed a substantial increase in the number of ticks in the several years preceding the appearance of the arthritis cases. Entomologists were evaluating all this, and they noticed that there was a specific type of tick in the communities where the arthritis was found. This was the Extracutaneous scapularis tick, and was only found in the areas around Lyme where people were getting the arthritis. Fortuitously, one of the entomologists studying the types of ticks in this region got bit by one and developed the erythema migrans rash. As it turned out, arthritis was a late manifestation of Lyme disease, and the earliest manifestation was the rash. So this is where we were in the 1970s. There's this entity known as Lyme arthritis. It's probably transmitted from animals to people by ticks, and that a rash can occur when the tick bites.
As we implicated Extracutaneous scapularis ticks, the next question was, what are they transmitting? It was actually a 7-year journey of trying things that didn't work. But Willy Bergdorfer at the Rocky Mountain Laboratory was the one who had the special expertise. He had spent his career dissecting ticks and describing infectious agents in organs in ticks. For the most part, it wasn't possible to culture any of them, so it was descriptive. And it all, throughout his career, seemed somewhat remote. But then, towards the end of his career, he was the person who had the special expertise to be able to dissect these minute Extracutaneous scapularis ticks, and within the midgut saw these spiral-shaped bacteria, which he then gave to Alan Barber, who was the one who came up with the first culture of what is now called Borrelia burgdorferi, the Lyme disease agent. And that was in 1982. 1983 really was the time that Lyme disease came of age, when it was completely accepted that this was a spirochetal infection that caused a disease that occurred in stages with different manifestations at each stage.
Identifying the organism that caused Lyme disease facilitated putting all the pieces together. There's a tick, the Exodes scapularis tick. It's about the size of a poppy seed. It bites people in the summer. Many of them get a very characteristic rash, and if untreated, patients may get what seems to be a severe viral syndrome, except that it tends to occur in the summer and not the winter, and patients may go on to have neurologic or cardiac symptoms, and about half will develop the arthritis.
Subscribe OET Gold YouTube channel for OET listening videos and OET podcast.
Because the causative organism is a spirochete, patients tended to respond to antibiotics. Some patients go on to have long-term symptoms that are probably not related to active infection, but may be related to a sustained immune response that occurs because of the Borrelia burgdorferi infection. So how does this all play out in clinical medicine? My colleague, Dr. Mary McDermott, and I talked to Drs. Auwerter and Hu about the clinical manifestations of Lyme as we know them today, how patients present, how to make the diagnosis, and how to treat Lyme. We also talk about the long-term complications of Lyme disease that some patients get. Let's start out with the rash. What does it look like, and how does it factor into making a diagnosis of Lyme disease? Dr. Paul Auwerter explains.
So an erythema migrans rash classically has often been described as a bullseye, and the reason for that is where the tick has bitten, there's usually an area that remains pinkish red and raised called a punctum. And then as the rash expands, the skin will clear, so you'll have an outer ring. Characteristically, and for case definition purposes, 5 centimeters has been judged the kind of size you would need as a minimum to really invoke an erythema migrans rash, although obviously early erythema migrans rashes can be smaller, but they tend to expand fairly rapidly. So for people that are unsure if it's an erythema migrans rash, you can easily observe it for a day, and it should expand fairly quickly. Typically, I tell people if rashes stay at a static size or quarter or $half size, those are probably not erythema migrans rashes, and certainly if they're dime or quarter size are more likely hypersensitivity tick bite reactions. The bullseye rash is the classical rash, but it may not be the most common in the sense that an ovoid homogeneous rash, meaning there's no central clearing, may now be the most common rash identified, mainly because people are diagnosing or going to the doctor and having their rash evaluated relatively early, so there's not as much opportunity for the rash to expand to become larger sizes, 10, 20 centimeters in size with lots of central clearing.
Okay, so it seems like the dynamic nature of the rash is what really distinguishes it from most other things. Is that correct?
I think it's not only the dynamic nature, because sometimes the rashes really are not terribly symptomatic. So often a partner may notice the rash. 30% of people have no systemic symptoms to it and no local symptoms. So they don't have a fever, they don't feel achy, or so on and so forth. So they may not know it's quickly expanding, but it's really the kind of ovoid nature to it. And, of course, that's just the single erythema migrans. People can develop a multiple erythema migrans, which has multiple, generally light-colored spots.
Let's imagine you're a clinician and you don't have a lot of experience with this disease, and you're not really sure if it is a rash related to Lyme disease or not. What do you recommend the next step be for a clinician in that position?
And this is sometimes more common in pediatric than adult populations, where there might be some confusion with tinea, for example, or cellulitis. So options are these. First, I would just make sure that there's a likelihood you're in an area where there's actually endemic Lyme disease. I think the chances of it being Lyme disease, if you're in an area such as, the Midwest, such as Kansas or in South Carolina, makes that less likely. But what we typically recommend is either observation, so one easy option is to have the person come back in a day or two and just observe if the rash is of an expansile nature, and that would help reinforce the diagnosis. The other is you can check serology, but with the caveat that serology will be negative most of the time, up to 60% of the time, in early Lyme disease, but then we would check a follow-up titer in 2 to 4 weeks afterwards to help see if this is indeed representative of Lyme disease.
Could you tell us where the disease occurs? Where are those endemic areas?
Lyme disease in North America has been expanding from its customary locations, which typically had been in New England and the Mid-Atlantic region, typically in coastal environments, but also along rivers and lakes. But it's been expanding inland so that many areas in through mid to western Pennsylvania, upstate New York, through the more mountainous areas into Vermont, New Hampshire, Maine. We see this now fairly routinely, also spreading into northern Virginia and along the Shenandoahs. Also, another focus of activity is in the upper Midwest, especially in the lake regions of Wisconsin and Minnesota.
And you mentioned that these regions are expanding. Are they expanding very rapidly, or?
So the areas that are endemic for Lyme disease have been expanding over the last decade since first descriptions of the 1970s and 80s. And it's slow but steady. It's not growing by leaps and bounds, but it is expanding into new areas. So, for example, Ohio is not thought to be typically at risk for acquiring Lyme disease in that state, but that is something that I think we'll have to bear watching over the next 5 to 15 years.
So that's the Lyme disease rash, and also the geographic regions of the United States where you get the disease. Lyme causes a host of problems, as Dr. McDermott found out from Doctor Who.
What are some of the extracutaneous manifestations of Lyme disease?
So the most common extracutaneous manifestations affect the nervous system, heart, and joints. Facial palsy is probably the most common neurologic symptom in the United States. Meningitis is also frequently seen. Radiculopathy and peripheral neuropathies are more common in patients who acquire the disease in Europe, but can occur in the United States. The most common manifestation of cardiac involvement is usually AV nodal conduction delays. And death due to Lyme disease, while rare, has occurred in several recent reports. And it was thought to be due to sudden death from myocarditis and conduction abnormalities. Arthritis is a late-stage manifestation, typically occurring months after infection. And it's important to distinguish this from arthralgias, which are very common during the acute phase of disease, but don't have true swelling. Interestingly, all of the manifestations of Lyme disease will resolve spontaneously in most patients over time, even without therapy.
Some patients will go on to have long-term sequelae of Lyme disease, as is explained by Dr. Auwerter.
First, I'd probably just start off by trying to distinguish what might be so-called chronic Lyme syndrome from post-treatment Lyme disease syndrome. The reason I say that is some people have nonspecific fatigue, musculoskeletal pains, poor sleep, neurocognitive dysfunction of a subjective nature, and healthcare providers will label them as having Lyme disease really without any good objective evidence that they've actually been infected. So I think many people that say they have chronic Lyme disease, in my experience, when I evaluate them in my clinic, we're putting together our own series, and it's probably something that 70 to 80% of people really don't have any good evidence of Lyme disease, although they've been told they have chronic Lyme disease syndrome. But for post-treatment Lyme disease syndrome, where people seem to not improve after antibiotic therapy, after what anyone would agree would be bona fide Lyme disease, what I think we know is that antibiotics of longer-term nature don't seem to speed improvement. What we can't precisely answer is what has been shown on an evidence basis to help. What I personally do with patients such as that is borrow considerations from other entities. So first, I want to make sure there's nothing that's a competing diagnosis, such as a sleep disorder, something else that might be a legitimate medical explanation. But then I'll usually borrow modalities from either the fibromyalgia literature or the chronic fatigue literature, where we might use cognitive behavioral therapy, We might use some pain modification approaches pharmacologically, low-impact exercise, pacing protocols, and many of the things that Simon Wesley originated and worked out in the UK for helping these patients on a non-drug and behavioral basis, if possible.
What do you do if you think someone has Lyme disease and you're not sure? You can tell from the discussion we just had that Lyme can present with a variety of symptoms, but the very characteristic rash is only present in a minority of patients. What diagnostic strategy needs to be pursued to confirm a diagnosis of Lyme when it's suspected? Dr. McDermott explored these issues with Doctor Who.
If the rash is clinically consistent with erythema migrans, really no further testing should be done, and the patient should just be started on treatment for Lyme disease. Testing in this case would not change clinical management, as a negative test in the early stages of erythema migrans doesn't mean that the patient does not have Lyme disease.
In what patient would you do a serologic test for Lyme disease?
So I guess if there's question about the rash itself, if it doesn't look classic, if there's concern that this may actually be cellulitis or something else, in that case, if you're not certain that it looks like a classic erythema migrans rash, then testing could be considered.
What is the testing that you would do?
Typically, we recommend serologic tests, and those are done in a two-step approach. The concept behind the two-step approach is to first screen with a high-sensitivity test, and samples that are positive on this first screening test are then retested using a more specific test to reduce the number of false positive tests. Current recommendations are to use an ELISA-based test as the first step, followed by something called a Western blot as the confirmatory test. So I guess while we're talking about this, while the addition of the second-step test is useful in reducing false positive test results, Western blots have been somewhat problematic in Lyme disease testing in that they're somewhat subjective and they can result in reduced sensitivity for detecting certain strains and species of Borrelia burgdorferi, particularly those from Europe, and even possibly the recently identified one in the Midwest United States called Borrelia mayonii.
So you were saying the problem is that for some other species, the Western blot results can kind of muddy the picture.
Sure. I guess the Western blots for some of these other species, and even for some species in the United States, can result in false negative testing. And they have been a source of decreased sensitivity when doing two-step testing.
So when a clinician orders these tests, should they first order the ELISA, or does it all come together in a package?
Most laboratories are now offering prepackaged tick-borne infectious disease tests. So sometimes they will include Lyme disease testing both with the two-step test as well as Babesia and Anaplasma. And some are beginning to offer Borrelia miyamotoi in addition to those. So often the clinician will just check a box and order them all at once. However, this will result in some errors.
What are some errors that are typically made in the two-step approach to testing for Lyme disease?
Probably the most common is diagnosing a patient with long-standing symptoms, and here by long-standing I mean longer than 30 days, with Lyme disease based on just an isolated positive IgM antibody test. The specificity of the IgM test is relatively poor, and in patients with untreated symptoms for greater than 30 days, the IgG tests for Lyme disease really should be positive. And if the IgG test is not positive, the positive IgM test is most likely a false positive test. So current recommendations are in these patients who've had long-standing disease not to even draw the IgM test, but with these tick panels, often they come automatically. So it's hard to kind of suppress your reflex to react to that positive test, but really they should be ignored if the IgG is not positive and the patient has had prolonged symptoms. The other common problems that we see with serodiagnosis with Lyme disease or use of these tests are repeat testing in patients who are already positive, who have had Lyme disease in the past. And the issue there is that both IgM and IgG antibodies can remain positive for prolonged periods of time, for years, and in some cases for life. Continued positive testing in the absence of new symptoms consistent with reinfection with Lyme disease does not necessarily require additional treatment. The real problem, unfortunately, is that there are no good tests for reinfection in a patient who has been previously reinfected and has positive antibody tests by serology. I think the final big pitfall that we see with use of serologic testing is the use of these tests in low or no-risk patients with nonspecific symptoms. And again, this is because none of the tests for Lyme disease have perfect specificity, and so use of serologic tests in patients with a low pretest probability for disease is going to result in high numbers of false positive testing and unnecessary treatment. And I don't think this is necessarily a reflection of problems with the Lyme disease test per se. I think we see this with most serologies, and it's just an issue of human biology, I think, in terms of how the antibodies form.
To clarify something you said earlier, if someone has been previously diagnosed with Lyme disease and presents again with a new reinfection, are you saying that it's really not necessary to diagnose or even treat those people?
No, absolutely not. So reinfection clearly does occur. What I'm saying is that it's very difficult to diagnose reinfection sometimes. Most cases of reinfection are diagnosed with a new erythema migrans rash, and those clearly do occur, and patients clearly can get reinfected, and they should be retreated. The difficult part are people with some of the other manifestations of Lyme where it's less clear that it's due to Lyme disease or to reinfection. In that case, you're really stuck because the serologic tests can't help you out at that point if they've been positive before. And so often you're left with a difficult decision on whether to treat or not treat in those patients.
I'd like to move on to treatment. So if a patient presents with a classic rash of erythema migrans, they live in an endemic area, what treatment do you select?
So typically erythema migrans is treated with oral antibiotics, and there are a number of different classes of drugs that are used, penicillins, tetracyclines, and second-generation cephalosporins. And of those, the most common are amoxicillin, doxycycline, and cefuroxime acetyl are the ones that are active. When choosing, we generally prefer doxycycline for a couple of reasons. One is that Anaplasma phagocytophilum that can be co-transmitted with the Lyme bacteria is easily treated with doxycycline, so you get kind of a dual effect there. And the second is that doxycycline of the oral antibiotics probably has the best CNS penetration.
What dose of doxycycline and for how long?
So erythema migrans, generally we use 100 milligrams twice a day. New studies suggest that we can treat for shorter periods of time. Probably 7 to 10 days is appropriate, so we recommend 10 days.
Is there any follow-up treatment assessment?
Most patients do very, very well with antibiotics during these early stages. And while patients can be seen just to make sure that they've resolved their symptoms, no real follow-up is generally necessary.
What is the cure rate from that initial treatment?
Probably on the order of about 90 to 95%.
If somebody calls you and says they've had a tick bite, is prophylaxis needed?
So there are a couple of things that you would want to check before recommending prophylaxis. So one is that if they have seen the tick, that the tick actually is one of the types of ticks that transmit Lyme disease. So that would be an ixodes tick, either a nymphal or an adult stage tick. And two, that it's been attached at least 36 hours and or is engorged. If they meet those criteria and they're within 72 hours of having removed the tick, then you can do single-dose prophylaxis with doxycycline, just 200 milligrams once. With that dose, there's a randomized study that showed about an 87% efficacy of antibiotic prophylaxis, although the numbers were small and the confidence intervals were quite large with that. The alternative would be just to observe the site of the tick bite. So when the site of the tick bite is known, the rate of erythema migrans development is very high, at least 80-85%, and in some studies over 90%. So just watching the site of the tick bite is an appropriate alternative to that.
And if a rash begins, at what point would you start treatment in that situation?
Yeah, so if a rash begins that's consistent with erythema migrans, we would start treatment right away.
Do you wait until it approaches the 5-centimeter size, or any rash you would begin treating?
You do have to be able to distinguish it from an insect bite reaction. So you do wait until it hits that size, or if the original insect bite reaction has gone away and then 4 or 5 days later you start to see an expanding rash, you could start treating at that point.
You mentioned earlier that doxycycline is your first choice of therapy for Lyme disease. What if a woman is pregnant or possibly pregnant?
Yeah, so amoxicillin or cefuroxime would then be the best choices there. Those are probably have the best safety track record for pregnant patients.
And can you tell us what doses, and is it the same duration?
Amoxicillin, 500 milligrams 3 times a day, or cefuroxime acetyl, 500 milligrams twice a day. And for erythema migrans, we would recommend 14 days.
Are there any effective non-pharmacologic strategies to prevent Lyme disease in, say, somebody traveling to an endemic area?
tick avoidance is mostly what we recommend. And the interventions I like the best are those that are simple and require the least amount of thinking. So showering within 2 hours after potential tick exposure washes away ticks before they can attach, and it's pretty simple to do. The other thing, if you're worried about bringing ticks in on your clothes, is to put dry clothes in a dryer at very high heat for 10 minutes, and that effectively kills all the ticks carried in on the clothing. A lot of other strategies have been looked at, including use of repellents such as DEET-containing repellents, nightly tick checks to remove attached ticks, changing the local environment. That wouldn't be so much appropriate for somebody traveling, but certainly for the home environment by removing leaf litter and wood piles where the ticks like to stay, and use of clothing impregnated with tick-killing agents such as permethrin. And all of them have some evidence of efficacy, but in larger trials haven't consistently worked, I would say. And we think that that's likely due to the difficulty with adhering to some of these things. Nightly tick checks, are difficult to do. As a parent, I can tell you the last thing you want to do late at night is to strip down your kids and check them for ticks. But if you do them religiously, they likely do work because there is a delay in the transmission of Borrelia between the time that the tick attaches and the time the Borrelia move into the next host.
Dr. Auwerter discusses the effectiveness of controlling tick populations and reducing the risk of Lyme disease.
For tick control populations, there are acaricides that are effective, and in fact, the CDC sponsored a trial comparing whether yards that are sprayed, people acquired less Lyme disease than unsprayed yards. The study suggested that indeed tick populations decreased, but they couldn't really find any impact on acquisition of Lyme disease, and it may have been purely a study design problem. So it's a fairly expensive approach in terms of spraying yards. The state of Connecticut has a very nice website on landscaping techniques to help reduce acquisition of tick-borne illnesses. And they very much like having a buffer zone of gravel or something that deer and other animals don't like running across, basically, between forest or other yards and your lawn. So there's a number of strategies that have been proposed. I can't tell you they're backed up by large amounts of evidence. We typically do suggest using prevention strategies that include things like using DEET-based sprays or permethrins that you might impregnate your clothes with in an effort to keep ticks off your person and from attaching.
Are there any vaccines in development to prevent Lyme disease?
So there was previously a vaccine available that was removed from the market due to low sales by the manufacturer. There are a number of different attempts to develop a human vaccine, but none of them appear close to approval currently. Most of them are variants of the original vaccine, which was based on a outer surface protein A of Borrelia burgdorferi. For dogs, there are a number of different antigens that have been approved, including one for outer surface protein C, but as far as I know, clinical trials for humans have not started for those yet.
A recent clinical trial published in the New England Journal of Medicine showed a lack of efficacy for antibiotic treatment for long-term Lyme disease. There are important limitations to this trial when trying to apply its results to U.S.-based patients. Dr. Auwerter explains the differences between the European and U.S. forms of Lyme disease.
So in Europe, most Europeans refer to Lyme disease as Lyme borreliosis. And there are perhaps some different characteristics. For example, people with the erythema migrans rash usually present a bit later. They may not be quite as sick as frequently as they are in North America, so perhaps less fever and malaise and muscle aches and flu symptoms. It also seems that there's more neurological involvement with borrelial infections in Europe compared to the United States, whereas in the United States, we tend to see in untreated people with Lyme disease more late Lyme arthritis, the classic swollen knee, which seems to be much less common with the strains causing Lyme borreliosis in Europe. The locations generally are the temperate regions, so some hotspots tend to be in Eastern Europe, including Slovenia, Austria, but it's really seen throughout the continent, but much less so in warmer climates, so, southern Italy, southern Spain, Greece, and so on. But Scandinavia, the British Islands, for example, all see that along with Northern Europe and Eastern Europe.